school?
My beginning is a little bit different from probably most of the people that you're going to interview, because I signed on in 1969, and actually it was the people in the dean's office of the medical school that were interested in what I had to offer. They were just barely getting started in the Whammy Program. And the medical school is full of people who are wonderful in terms of their specialties and clinical care, but many of them, most of them, never had actually practiced in the community anywhere. And yet here was this plan afoot called the Whammy Program, the Washington, Alaska, Montana, and Idaho at that time program, to farm out students, medical students, in their probably third and fourth years for clerkships in remote communities. And here I was, somebody who had practiced in remote communities. So I was actually hired by the dean of the medical school, who I wasn't hired. I was a person of interest to the dean of the medical school, and he wanted me to go around and talk to appropriate people. So I was assigned to talk with Dr. Bob Petersdorf in medicine and Dr. Tim Oliver in pediatrics and a number of other department chairmen who said, "Yeah, you sound interesting, but we don't know what to do with you." Well, in the meantime, in ways that I never did quite have a background to understand, Bob Day had been taken on as faculty in what was then the Department of Preventive Medicine. And he was very interested in community service, and he was up to his ears in helping to develop the Model Cities program. And through one thing or another, one of the people that I was interviewed by was Dr. Tom Grayston, and he said, "Well, I think we could find a fit, in our department, but you're pretty old to be starting on the academic ladder." I think I was 51 at the time. And and so he said, I think we should start you maybe as a senior associate. And I said, "No. If I'm going to be here, I'll start as an assistant professor." And he looked very gloomy about that. Who had ever hired a 51-year-old assistant professor? But anyway, we brought it about, one way or another. And I was sort of awarded to Bob Day to shepherd. And Bob was wonderful. He was one of the first men that I ran into who really didn't care what gender you were. He was more interested in, what you could do for the things that were on the front burner for his program. And he understood that I was there to introduce medical students to community practice, to public health at the community level. And most of the other people in the School of Public Health were very specialized academics who really, I think, thought I was some kind of a maverick that they were probably going to have to tolerate for a while, but hopefully not very long. So I started out with a bit of a problem in asking people to see where I fit in. But as time went on, I was very lucky because it was a time when there was a great deal of student unrest, and students wanted something different from what the establishment was giving them. And I was certainly able to give them something different because I couldn't give them what the establishment was giving them over in the specialized departments of the medical school anyway. And I think people liked the idea that my position was attracting students, and I was, of course, advising them to take epidemiology and biostatistics and anything else besides the courses we were offering in community medicine. And after a while, not only were we having medical students, but we were having wonderful people coming back from a couple of years in the Peace Corps who already had their MDs, but they had discovered that their MDs didn't do much for the big problems in third world countries, that what they really needed was some public health expertise, that you could do all of the personal health care that you could possibly fit in a day, and you couldn't scratch the surface of the problems compared with clean water and a place to live and decent food and all these things, to say nothing of immunizations and so on. So we had a pretty good student body going before very long. And meanwhile, Bob Day was faced with the problem of financing my position. And he explained to me very delicately that I was going to have to help, and that one way to help is to get some research going. Well, that was fun as far as I was concerned. So I began to develop grant applications and got research going, and I got support going from some private foundations for students that in the early 70s I was sending over to the Yakima Valley to work on development of the Farm Workers Family Health Center in Toppenish. I had several grants that gave them very tiny stipends for the summer for about 3 or 4 years. And they went over and pitched their tents and worked providing various kinds of health care for the migrant workers, who were a pretty sorry lot in that time compared with now, and even though now isn't great, then was pretty awful. And it was then that I really got introduced into heavy politics, because we actually, at one point, for example, got a $300,000 grant from the federal government to continue work on developing the Farm Workers Family Health Center. And we had the check in hand. And the congresswoman from that district, with the urging of the growers, who were the county commissioners at that time, got the payment of that check stopped because they did not want this kind of service to be offered to the migrant workers. And I was asked at one point during a very heated period to leave a hearing and leave the county, and told that I should get my students out of there. And the students refused to go, but since I was going back anyway, I did leave the county on that particular day. I came back the next week. I came over once a week to see what the students were doing and help what I could. And they were working with a number of wonderful people over in the valley. Some both Catholic nuns and some Protestant churches, church workers who were trying to help the migrants, the Chicano field workers. And things simmered down enough, and we finally, I think with the help of Senator Magnuson at that time, got the check released after quite a period of time.
Wow.
And although countrywide there were a number of these health centers set up, I'm happy to say that that one is still thriving this day.
Absolutely, and very supported still by the school.
Yeah.
A lot of the people in the Pacific Northwest Agricultural Safety and Health Center, there's a Dr. Kiefer who goes over usually about once a week or so. And
that's great. I didn't know that.
And then there's a number of surveys and other things that have been funded by Panache. And one thing they're really working on is trying to stop the take-home pathway for pesticide residue. So it's what got started in the 70s is actually thriving right now.
I know that it is. I didn't know about that program. That's wonderful.
Yeah. So
those are the things that need to be done now, countrywide. But anyway, that was a wonderful experience, and I was gradually promoted. Well, I shouldn't say gradually. I got promoted pretty fast. And I never knew whether it was because I really deserved it or because they were just desperate for women. All over the university, they were looking for women, senior women, to be on committees, review committees, and that sort of thing. So I served on everything from reviewing whether a forestry program should continue in the School of Forestry to the President's Commission on Scholastic Athletics. And that was one I had to quit because I was, it's the only one I ever really gave up on. I realized it was full-time if I was going to decide whether football players really deserved to be in the university setting scholastically. And I decided it just wasn't my job to do that. But that's the only thing I think I ever gave up on that they assigned me to do.
The problem for women and minorities and needing representation on the committees, but you can't take them away from their work so they can get tenure. And
it's very hard,
it's
yeah.
balance.
And then by that time, I not only was involved in the medical students, and I was on the student progress committee of the medical school, and at times on the curriculum committee. And then at the same time, my own department, by then it was a department, it was a department of the School of Public Health, wanted me to do things there, and so I had to do a lot of balancing. And I was fortunate in that the things that I wanted to do were popular at the times that I wanted to do them, which is more than happens to a lot of people. I mean, a lot of people are before their time or sometimes after their time. But my luck was to be where the action was at the time they needed something that was in my background. So I had fun, even though it was intense sometimes.
So what about those early days where usually it's just a school of public health, but at Washington it was a school of public health and community medicine, and it's been that way for its entire span.
That was at the insistence of Bob Day and me, really. we had to have something that really covered some of our interests in community work. And we had to let people know that it was there. And so the name is cumbersome, but it did tend to assure people that there was that kind of activity available.
You know, with the range of issues that the School of Public Health is dealing with now, from bioterrorism to natural disasters, disaster response, newly emerging diseases with West Nile virus and bird flu and obesity and just the whole variety of issues. Could you recall for us, please, some of the issues that were important in those days? You spoke about how, the timing was right. What were some of the things that you worked on? There's the migrant health issues, but what were some other issues?
I think recruiting minorities into healthcare was a big issue, and many times with affirmative action, of course, we got students that were not traditional, and I think advising them was very difficult for most faculty members in the medical school. They didn't want to spend the time because it took away from their clinical and research responsibilities. And B, they didn't really know how to respond to these students who were different from anything that they had had before. I mean, we had Chicano students who had literally come from the vegetable fields of Southern California and had been recruited because they were smart through their colleges into medical school, but culturally they were very, very different from the kind of hidebound medical student that the faculty had been accustomed to. So that was a big part of my responsibility. I had a lot of advisees who were minority students and increasingly women. Women were absolutely unrepresented when I first came in 1969. Minority and women recruitment was important. And then really making it work once they got in. Recruiting them was one thing, but keeping them
Retention.
on the path and retaining them. And we were successful for the most part. I think I personally lost only one advisee from just absolute inadequacy to accommodate to the cultural milieu that they got thrown into. And he was a Chicano, interestingly enough, from a rather relatively privileged background. And I think maybe that accounted for the fact that he did not want to accept the kind of accommodation that we were trying to offer a lot of the students of his background, his ethnic background.
Mm-hmm.
We had an increasing number, really quite a few number of black students in the early 70s. And I ended up as advisor to certainly several of them. And that was a challenging thing too, because they were, they tended to be more assertive than the Chicanos. The Chicanos might have been resentful of perhaps some of what they considered unusual treatment, but the blacks were more assertive about expressing it, and I certainly understood where they were coming from.
Well, that was certainly a period of great unrest and
Oh, terrific.
the marches. I mean, just here in Seattle, when I think back to those days, you know, we had the bombings and the marches and the Black Panthers, and it was definitely a time of coming out.
Yeah.
And Black Pride, and
We had a sit-in at the dean's office in the medical school. The hallway was covered with students who were just sitting on the floor and expressing quite a bit of aggression, I might say. And they asked for faculty volunteers to go and talk with them. And I did it. And several others did too. And for the most part, I think we were the kind of people that had been working with them anyway. So it was not as hard as it was for a couple of the faculty members who did it because they thought they should, but they really hadn't dealt with it before. But we made it through all that. Dr. Gus Swanson was the dean of the medical school, just newly hired at the time he hired me. And he was a marvelous personality. And he was very understanding of student unrest at the time. So I don't think we had as bad a time as they did on upper campus. And by that time, Dr. Hogness had left health sciences and was president of the university during the worst of the unrest on upper campus. And he was a fine person, too. So in a way, I think we didn't have as bad a time, certainly as they did in some of the campuses.
what about some of those other leaders in the school, Grayston, Thompson, Day? Please recollect for us some of those thoughts on those gentlemen.
Well, of course, I spent a lot of time with Dr. Bob Day, and he was just a jewel in terms of working supportively with me, but he left me very much on my own. But I could always go to him and say, here's what's happening, and what do you think I should do? Or how does this fit in with what else is going on? And he was always a good source of support from that point of view. In terms of Dr. Grayston, a great gentleman, always very nice to me, but I don't think he ever quite understood what I was all about. He was a very prominent man in infectious disease research, and I think most of the people in public health in the Department of Preventive Medicine, let's say, when I first came on, were pretty much focused on infectious disease. And they were little bailiwicks or kingdoms, pretty much on their own. And the glue that really tied them together more than anything else was the Department of Biostatistics. And Donovan Thompson, who was the chair of the department. And he was just a wonderful person. He loved his faculty. He was another one who was very supportive of women. Dr. Wall and Dr. Feigl were just slips of girls at that time, and obviously very promising people, and he encouraged them. But he was very good in recognizing that some of what I wanted to do needed statistical assistance. So I could always go to him. I was no statistician. I just simply had very little background in it. But I could go to him and tell him what I wanted, and he would find the right person to work with me. And as I built my research team up, we added 2 more women, whom I want to mention because they were very important to me and to the school. Dr. Marilyn Bergner, who was a medical sociologist, and Dr. Ruth Bobbitt, who was a behavioral psychologist. And all 3 of us needed plenty of help with data management and statistical analysis. And Donovan Thompson was always there to give us some help when we needed it and point the right graduate students to us. And that brings me to the research program that I did and how we really got that into the school and into the student consideration and curriculum. Well, I mentioned before that Dr. Day had said I'd better find some research if I expected to be promoted. And that was okay because I wanted to do some anyway. One of the things that my husband and I had noticed in Montana, and particularly my husband, who was a cardiologist, and who worked in a very avant-garde but conventional type of medicine, in something that was very new at the time called group practice. We went to Montana so that he could join a group practice of about 35 people. And I was left to find my way with whatever I could, raising 2 small children and still keeping my hand in. And I soon found things that were really counterpoint to some of the things that he was doing, because he was serving a huge need in a big population of people. Most of eastern Montana, east of the Rockies, used Great Falls at that time as kind of a referral center, and the Great Falls Clinic was part of it. Well, to get back to what we had noticed was that there were quite a few ways of doing treatment of various diseases in medicine, some much more expensive than others. And sometimes you'd get a very good clinical result, but the person wouldn't necessarily be a lot better in terms of what he actually did and what his behavior was and his activities of daily living and his quality of life. And so John, my husband particularly, wanted to develop some kind of a measurement tool to measure quality of life with treating things in various ways. And that was really the origin. I certainly agreed, because I was seeing the other end of the spectrum from what he was. I was taking care of landless Indians that had no access to care at all. I was doing tailgate medicine, which Doug remembers some of, I'm sure. I'd gather up all the free samples, which were numerous in those days, and go out and to an area called Hill 57 and treat running ears and sore throats and things that weren't getting any help at all from the mainstream care. But I remembered all this and wanted to develop a really sophisticated instrument for measuring outcome of care. And once again, I was lucky enough to be right at a time when there was huge interest in this. Because Medicare had come in and was beginning to balloon in terms of expenditure, and people at the federal level were saying, well, look, there are all these differences in the way people are treating things, and what is the best way? What's the way to get the best result for the cheapest price? And so when I came up with this proposal, there was great interest in it. And I knew I needed a lot of help. So Bob Day, once again, assisted in the recruiting. Dr. Bergner is a medical sociologist, and I found Dr. Bobbitt, who was an expert in mother-child interaction in higher primates, which sounds unrelated, but you measured behavior quantitatively in that sort of thing. And that's what I was looking for, how to really, how to give a fairly quantitative answer to various ways of approaching disease problems. And so the three of us, the three women, Dr. Bergner, Dr. Bobbitt, and I, put together a huge grant application. We were asking, and this doesn't sound like a whole lot now, but at the time, it finally added up to well over $1 million to develop what's called the sickness impact profile. They decided that we deserved to be looked at least, and they sent a huge site visit of about, I think there were 15 or 18 people that came, and by that time we had engaged space on Roosevelt and 12th Street in the building that's on the corner there. Can't remember the name of it.
Well, the U District building?
Yeah, I guess it was the U District building. And they came and sat around in a great circle. And they kept looking around sort of nervously, and I finally decided just to face it head on. I was listed as principal investigator. And I said, I know you're looking for the men. And we did have men, but they were very young guys who were computer nicks and psychologists. Bill Pollard, Bill Carter, very young and very smart. So I gave them quite a spiel. I remember I just felt I might as well let them have it, because I thought I'd been told that the chances of our getting funded were not great. I was going to have to trim sails and maybe find some other people and so on. And I said, here we are, 3 women, all of us approaching a certain age, because both Marilyn and especially Ruth, who was almost as old as I, had a lot of experience in what we purported to do. And I just laid it on them and made them listen for about 10 minutes as to why it was a challenge to them to rise to the times and fund us. And long story shortened is that they did.
Yeah.
And actually we had very generous funding for about 3 years, and turned out an instrument that was quite widely used at the time, and has been used as a basis for much more sophisticated measurement now for very individualized problems. And one sad thing is that I was told a couple years ago that in that particular year, the sickness impact profile was the most highly cited paper that had come out of the School of Public Health. And I said, but why? And the sad thing is that it was because it was being used as a basis for studying outcomes of people who were injured in the both Iraq wars.
Oh.
And particularly people who suffered very severe trauma. Because the sickness impact profile is a purely behavioral measurement. It's not what you can do, but it's what you do. Mm-hmm. And, it's not that for example, if I had to, I could walk 4 miles today, but I don't do that. And I'm doing well if I walk a mile. So I would have to answer if I were responding, I walk a mile, to a question of how much do you walk? How much have you walked today or this week? Which got away from some of the older instruments which measured capacity rather than behavior. And we also had a psychosocial element to it, which people hadn't tackled before. How people related to their family, not how they were able to relate, but what they actually did. How they related to their own needs on a day-to-day basis. Do you dress yourself every day? Do you, we got down to things like, do you fasten your own buttons? Mm-hmm. It was a fairly lengthy instrument. And we tested it with great care on several different diseases, ranging from the treatment of hyperthyroidism, which is a very debilitating disease, but responds to good treatment amazingly well and rapidly. So we knew it was a good one to test. Mm-hmm. And total hip replacement was relatively new at that time, and that was another excellent one to test, because if you got a good result, it made a huge difference in your life. Mm-hmm. Dr. George Kenny in Pathobiology. Well, Pathobiology was a great mystery to me. And it turned out, to a lot of people in the School of Public Health. There was always discussion as to whether it should be, the department should be amalgamated with bacteriology and such in the medical school, and particularly as viruses became sources of study. But George was beloved in the School of Public Health, and I think he liked his independence, and so certainly during all the time I was there, it remained an independent entity. And there were wonderfully interesting people, and I know some of the seminars were extremely informative, but I didn't understand a lot of them. But he was such a good spirit, and just another one who would join in and just make a good feeling wherever he was. Oh, the extended degree program was, I'm not quite sure how it got started. It certainly wasn't my idea, but I did get into it pretty quickly, developing curriculum, and once again relating to students who had been working for several years, really, mainly in public health offices in Alaska and Montana and Idaho. I think in the first group there was even a couple from New Mexico and Colorado. And their needs and interests were very different, of course, from most students that we had. They really wanted to get some nitty-gritty of what they should be doing in their jobs and how to do it. So we had quite a time, I think, finding a curriculum that really satisfied them, satisfied their needs. I had a hard time sometimes convincing them that they needed as much epidemiology and biostatistics as we wanted them to have, but they really needed that, at least the concepts in the background. And we had some growing pains in it, but it went really quite well. And I guess countrywide, a number of others started up about the same time, so we weren't getting people from quite so far and wide toward the end of my time that was there. But it, I think, was a successful program. And we have at least 2 or 3 people who have been up here working in the health department who got their MPH in that way. And a couple of them have moved on to different and probably more responsible jobs than they would have had without that program. So it has served its purpose, I think, very well. And the one person who has stayed here, who is head of personal health services, I think has started a couple of programs that she wouldn't have been able to do otherwise if she didn't have the background. So it's been, I think, a useful thing for communities to have people in it that have achieved their degree in that way while they worked. It made some very long weekends, I might say. Well, Fred was a wonderful example of the sort of person who came back from an international experience. In his case, it was eradication of smallpox. And he certainly had a grasp of some of the factors that affect health that are not really responsive to direct clinical medicine. And he's a pediatrician by background, and that was helpful because we didn't have one of those until he came. Both Dr. Malcolm Peterson and I were internists by training, and I had done a lot of pediatrics by virtue of need, but I wasn't trained in it. And I hope I never did any of the kiddies any harm, but I certainly welcomed someone who was a specialist. And Fred has just done a wonderful job, I think, of growing the program and getting interested in getting people out to the community and getting community people in to get some more background and training. I got a long letter from him just a few months ago, and he was bringing me up to date on everything from his family to what he was doing. And
We tell you about the community-oriented public health practice program that
Mhm.
has really started.
Mhm.
That's a continuation.
Yeah. So he was very gracious about thanking me for mentoring him. I didn't know I had done it, but it was good.
I wonder how many others are out there that you don't know about who
Lots.
credit you with a turn or pointing them or helping them at a key time in their life.
Well, there are a few out there that have learned some things not at all related to medical care. I got a few medical students doing wider reading than they were accustomed to, and trying to get them interested in just being part of the greater world.
Wider interests.
It's so easy to,
Yeah.
just go down one very narrow channel, and I've never been able to do that. I think I was once accused of having interests that were a mile wide and an inch deep.
Like some rivers we know.
Yeah, right. And then Dr. Malcolm Peterson was certainly a great help to the community medicine program. He came to us with a really national reputation for a knowledge of community needs and interest in minority groups and everything from health services needs to environmental health needs. And he served as chair of our little group for the period that he was there. He wasn't with us an awfully long time before he, for reasons I don't even remember, decided to return east. And then, of course, didn't live very long after that, unfortunately. But he was a very good spirit. He was always upbeat and always full of ideas and full of encouragement. Certainly attracted students. There were people in environmental health that we worked with fairly closely on a couple of matters. Dr. David Disher was one. He left the university to go down to one of the Stanford spin-offs after a few years, but he was a very active person and had a lot of interest in the way occupational health affected the health of communities. There was a lot of interest in environmental health early on in my time there. In air pollution, which was kind of unusual at that time to have so much research going on in. I appreciated that.
And then did that lead to our particulate center?
I'm sure it did.
Did we have
yes.
kind of a nice base of people whose research interests were there, and that center then
That's right.
came out of that? Okay.
Yes.
Jane Koenig was there in the early days.
That's right. Mm-hmm. I never knew the people in environmental health terribly well, but I was interested because as I would go out to some of the Whammy Program sites, I could see occupational problems or occupational health problems that concerned me. And I managed to involve someone in the faculty in thinking about them, at least. I should mention Dr. Joe Patterson and, of course, Dr. Dick Smith. Dr. Smith started the MEDEX program, which was really a spin-off of community medicine. We weren't closely connected, and geographically we were very separated, but he again was another excellent leader, and I got to know him quite well, and we would sometimes talk over curriculum problems for the medexes and such, and I would argue with him about accepting some women as medex, which they did and do now very readily. But the whole idea in the beginning was to take medexes from the, or medics from the Vietnam War and upgrade them with what they would need in community service and medical care. And of course there weren't any women involved in that, but it was clear that some of the women would really like to move into that category, and the ones most logical to do it were nurses with less background in nursing than some had, and yet were very well prepared to move into a medX position and curriculum. And then it happened.
Now directed by a woman.
Is it? I didn't know that.
Bruce Baldwin.
Oh, that's right. Yes, of course.
Yeah.
And she's been with the
For quite a
program.
while.
I'm glad she's director. That's very nice. Dr. Joe Patterson was another community medicine person who came with us for quite a while. He was particularly instrumental in working with Bob Day in the Model Cities program. And he was very good at attracting minority students. He was black himself, and very outgoing and very personable. And it was a great help with some of the minority medical students. He became a very good friend. Another person I should mention is Dr. Ed Perrin, who was in biostatistics, and I'm sure still is, although he's
And health services too.
Yes, right. And he became chair of health services. He was another person who was very supportive of new ideas. And he was very instrumental in helping me, introducing me actually to at least one private foundation that he was associated with that helped me with grants and travel to third world countries, particularly in this hemisphere. The Milbank Foundation.
Oh.
And that was a very helpful thing for me.
Betty, where did your travels take you in the third world?
Mainly in because I came on into that program rather late. It was mainly the Caribbean and Central America, and so I visited clinics and medical operations in Puerto Rico, Jamaica, Mexico, Costa Rica, and saw how they were organized and how they were delivering care. I didn't get it on the earlier years when they went to Brazil and Chile and further south, but I really benefited a lot from an association with people from all over the country in the Milbank Fellows program. That was a great thing. And Ed Perrin was completely responsible for getting me into that particular situation. I might say one of a minority of about, I guess, 3 women and about 30 people. So it was a nice experience.
Well, you really were at you had a good coin of vantage to see how the demography of public health changed, because when you came in, it sounds like women were few and far between.
Except in the lower echelon jobs, right.
And now, with a woman dean, with several of our key players in the School of Public Health being women, and with our distinguished alumni of the program.
More than half our students.
And more than half the students now in the program being women.
It's a whole different thing.
You've really seen a transformation and a demographic shift on your shift, so to speak.
Oh, very much so. Yes, in medical school too.
Mm-hmm.
No, I'll just briefly touch on this because it's kind of burnt into my memory. There were quite a few women in the School of Public Health, but they were all in very much lower echelon jobs. But I could plainly see that they were doing things that, if they were men, they would have been long since promoted. And when I was made, again by courtesy of Bob Day, an associate dean, I sat in on things like promotion and salary discussions. And I said I thought it was time that we looked at the women in the school, and some of them I knew were doing jobs that they would have been long since promoted to be at least associate professors for, and that the school was ignoring the 6 years up or out rule. And so I said, we'll consider promotions or they're out. Well, that was quite a statement. Threatening, I think. And so they were promoted in due time. But I do remember one delicious faculty meeting, just of the full professors. And I won't name any names, but there was one woman who surely deserved to be a full professor in another department. And the statement was made by one of the kind of crusty old members of the department that she was a difficult person and kind of grumpy. And there was this long silence, and I said, if a lovable personality was necessary to be promoted to full professor, this room would be mainly empty. There was this, how dare you, sort of.
Twang.
Oh, that's a good one. Oh my.
And she was promoted. But it's just the sort of thing that you had to do. And I was there at the right time to do it, and old enough, so I didn't care. I mean, if they wanted to, it would have been hard to fire me at the time. But whatever they wanted to do was okay with me.
Yeah.
I was wanting to say it, and I said it. And I don't think that kind of thing is necessary to say today. Not that there isn't still plenty of differences, but it was extreme. And you're right, I did see really the whole development.
Any other of those large shifts, or are there any other trends or changes that you saw from when you first signed on in 69 to when you left in 90, left really?
I think the one that I've noticed the most is a recognition that so many problems that we face are interdisciplinary. And I think when I first came on, and in fact during my own training and such in the 1940s and 50s, the disciplines were so demarcated. And it was ridiculous because particularly public health is completely intertwined with everything from the law to bacteriology. And we weren't really taking advantage of that in curriculum development. And I think there is a trend, and it's still going on, to see that everything's connected with everything else, as John Muir said. I believe he said everything is hitched to everything else in the environment, and it's certainly true in not only in health problems, but social problems, and I think it's important, and it has become, increasingly, I think, coming into our awareness that we need to broaden people's backgrounds in order for them to understand some of the problems we still have to solve. And I'm sorry to say that sometimes we have to relearn things that we really should have learned from history, but look at us today.
Yeah.
Public health has always seemed so interdisciplinary. That's what it is.
It is.
And we still have trouble with the departments.
Yeah.
Interconnecting because people.
Well, I think one thing I remember is how toxicology got gradually folded into environmental health, and our first toxicologist came from Upper Campus, and visited a few times a week. And that sort of thing. And it's just an example. And we had, for example, along the way, we had students who were interested in Indian health. And we then got quite a close relationship with at least one faculty member in the School of Law that was interested in law as it affected Indian populations. And he's an expert on it. And this made a big difference because we realized that some things were going to have to be changed legislatively before some of the problems that we were looking at could be solved.
Yeah, the relationship, just on the bioterrorism thing, when we did the conference, we brought in the nation's leading authority on public health and law. And just in terms of trying to rewrite quarantine laws, what happens when an infected member of the population does not want to be quarantined? I mean, what are we doing? Are we trying to shoot to kill, or I mean, just the whole question of what rules are on the books, and most of these rules are from a much earlier period when the issues weren't as clear, or the consequences weren't as dramatic.
Well, I haven't talked much about my experiences in Montana, but one of the things that was a big problem is that tuberculosis was rampant on some of the Indian reservations, and particularly among the so-called landless Indians who ended up without a reservation and were in little conclaves.
Pockets.
And treating them and staying within the law, but convincing them that they needed to do it for the sake of their young ones and so on, was very challenging, and that's where I really learned a lot about cultural differences. I mean, I have prescribed horn-toad medicine for tuberculosis because that's the only way I got Gilson Laframboise to take his streptomycin. So I thought, fine,
So it works.
the horn-toad medicine is just fine. But, that's very hard for a conventional, was very hard for a conventional physician to do or to accept. Who knows what's in horn-toad medicine, but we knew that Gilson Laframboise had been taking it for a long time for anything. So there he was with tuberculosis and probably 8 or 10 grandchildren.
Well, that's one of the things that I see as a hopeful change in that what they now call complementary or alternative medicine is more and more being merged in larger practices or even two-people practices. One, a naturopath, and a graduate of Bastyr, and a traditional
Right.
doctor coming together to
Right.
form a clinic that gives you both the holistic care and the conventional medical approach.
Right. And, oftentimes so-called Western medicine people will say, well, we know that some of those things don't do any good. And I say, well, we know that some of the things we've done in the past haven't done any good either, so...
Or have terrible consequences.
Yes, right. So, let's keep our minds open.
Yeah, at least with the supposed alternative medicines that don't do any good, they also don't do any harm.
Right.
And is the very first precept of the
And if the
Hippocratic Oath.
patient wants it and feels better, that makes a huge difference.
If you believe in it.
Yes.
I mean,
Belief is very
that
important.
placebo effect.
Well,
Gosh, guys.
can you think of anything you'd like to conclude this session with?
Only that I think that the fact that we got that program started has been a real benefit to at least the Pacific Northwest. I think we have affected practice at the community level more than we can measure at the present time. And I'm glad that it's thriving.
Thank you.
I'm making a note to send a mug to Betty.
Let's see. I'm right there.
Yeah.
Hi, Betty.
Let's see. There.